welcome to another episode of CRA Arthritis from Quebec City. It's Arthritis Consumer Experts' 9th consecutive live event at the annual scientific meeting of the Canadian Rheumatology Association and Arthritis Health Professionals Association. We're really happy to have with us today Dr. Stephen Katz, a leading Canadian rheumatologist who's based in Edmonton, Alberta. And we're going to talk to Dr. Katz about a couple of presentations he's making here at the meeting and looking at models of care from the region that he is based in. So Dr. Katz, welcome.
Thank you.
So maybe to start off, you're here from Alberta, and I think you have a couple of poster presentations.
Yeah.
For our audience, maybe you could just give a brief description and maybe some of the key takeaways that some patients might be interested in.
For sure. So two probably very different posters, but under the auspices, I think, of access to care and patient education. So we have one looking at our website, so albertarheumatology.com, which services Alberta patients, but really is viewed nationally and internationally, but looking at interactions with patients or what we call rheumatology interested folks during the core of the COVID-19 pandemic. We were very quick to be able to, like many arthritis organizations, to get information up on our site. And what we haven't seen a lot of is what that interaction has been like, and to have a better understanding of that. So we're able to report using simple analytics that sites have to show kind of what that interaction is being, which is quite good, but also that we really hit our target audience, being Albertans, very much so, compared to kind of other resources on our website where, yes, certainly used in Alberta more than other places, but we'll have 50% of our visits even outside of Canada, whereas specifically for COVID-19 and when vaccine came, very Alberta focused compared to, so we really hit the target audience and seemed to be very well used.
Congratulations on that. And the second presentation?
Second one, looking at methotrexate. So we know methotrexate remains kind of the gold standard medication for what we do. We think that subcutaneous injectable methotrexate is a more effective and probably at least as well tolerated, not maybe a little better than pills, other than that it's an injection. And yet, it's a medication that's been around forever, and a lot of patients are still old style syringe and needle. There's some better products out there, but it's still not ideal. We look back at what's gone in diabetes, and they have insulin pens and things like that. So we did some kind of initial work looking at rheumatologists as well as patients' interest of kind of going into, well, not the next century, but at least equal to some of our other areas of medicine in terms of having a device that is more patient-friendly, easier to use, and if it achieves that, then adherence, patients taking it as they're supposed to, happens more often, which means it works better, which means maybe we get faster control of arthritis, which means maybe we don't need more expensive and complicated biologics and advanced therapies. So this is a first step in terms of seeing where we can go down that path as well.
Really exciting because, as you said, it's a foundational therapy that's been proven over the years for treatment for patients living with inflammatory arthritis. Maybe even step back from the actual administration questions. Often our patients, when they consult with arthritis consumer experts, one of their first questions and their concerns is they don't necessarily know a lot about the drug, but they heard it's a cancer drug. Yeah. And that really, really scares them.
Absolutely. And I think for anyone, their first diagnosis of rheumatoid arthritis, it's a lot of information you take in and medications which sound scary, right, at first glance. And it's always, it's easy for the practitioner who's done it hundreds of times and knows what that end result, but when it's you and you have to go on that treatment the first time, it's very challenging. What's interesting about methotrexate is it is used to treat certain types of cancers, but the way it's used is very different, right, which means the potential risks are very different. So for methotrexate in rheumatology, we call it low-dose methotrexate. We're talking about once-a-week dosing at very small doses. When it's used to treat certain types of cancers, we're talking about doses that are 10, 20 times higher daily dosing. The side effect profile is very different. What's unfortunate is that if you go to a lot of particularly non-rheumatology sites out there, They will provide all the side effects, regardless of the dosing. When you get it at the pharmacy, they are obligated to provide all the side effects, regardless of the dosing, and that creates kind of a confusing picture in terms of communication.
Well, thank you. I mean, that goes a long way, I think, from our audience point of view in terms of understanding that distinction. Really, really important. If they still are unsure, we encourage you to go to the Arthritis Consumers website. We have a lot of information there about medications. I just want to go back. I mean, you've been talking about, I think, the standard of care, delivery of care. And I do know you and your team in Edmonton are not just focused on the market in Edmonton, but I think you also are involved in the delivery of care in Northern Alberta and even up into Northwest Territories. Can you just tell us a little bit about the state of models of care and delivery of care in that big region? It can be very challenging.
And it is, and I think it remains a challenge. I mean, I think for a lot of us, it's still that older model of you come and see the rheumatologist, and that is your resource when it comes to arthritis care. And I think that's not the best way to do it. It's looking at newer models of care where it is a rheumatology team is going to provide, I think, better access because you're expanding the totality of capacity, but also better quality care. I mean, I'm very fortunate in Edmonton. I have a clinic with a pharmacist who's on these posters with me, Dr. Jill Hall, and we do a weekly follow-up and plantar arthritis clinic. So while I'm seeing patients, she's also seeing patients fully, doing physical exam and full counseling, but also doing cardiovascular risk reduction and vaccine talks and bone health and all these things. So patients are getting more holistic care, getting the total picture. Our capacities increase as a result, and we have the data. Patients love it. So this is a model that works in this small bit, but if we can do it particularly for areas that are harder to access, right, where, be it Northern Alberta or Northwest Territories or wherever it might be, I think we can provide better care, easier access for patients so they don't have to travel as well, which means better outcomes in the short and long term.
I do know that the work you're doing in Alberta, Northern Alberta, is considered a best practice, so congratulations on that. If our audience is looking for more information, I know you dropped that website. Maybe just do that one more time if they're looking for more information.
Absolutely. It's a long one, but Alberta Rheumatology.com. If you just Google it and you don't have the spelling quite right, it'll still come up.
Fantastic. Well, thank you for joining us today. It's always nice to see somebody out from Alberta, and as you know, we're based in BC, so we're neighbors. Absolutely. And we do actually quite a bit of work together. So thank you very much for joining us today.
My pleasure. Thank you.